what we're talking about is healthcare today. We've both gone super deep.
Yeah.
We have a lot to talk about. If you're an American, you probably know that our healthcare system is super flawed. And I kind of want to set the stage to this with a quote from Warren Buffett, who has called America's healthcare industry a tapeworm in the American economy. And I think that is a brilliant way to describe it. It just sucks money out of people. And of course, I was thinking about this as I studied. That money is going to people, right? It is paying someone's salary, but it's so often not paying productive salaries.
Right.
In an industry,
it's non-value added salaries.
Yeah. In an industry where there should be so much research and development happening, so much of the money that's in it is kind of going to waste. So I was going to start with, how is our healthcare, like quality wise?
Yeah.
What does it look like? It's bad.
Yeah,
It's incredibly bad. We have like the worst outcomes versus all comparable rich OECD countries.
Yes, I want to give you some context here. For the national healthcare systems among high-income countries compared through the Commonwealth Fund, compared to 11 high-income countries, we came 11th. Yeah.
We have the lowest life expectancy. We have the highest infant mortality rate. We have the highest neonatal mortality rate. We have the highest maternal mortality rate. It's pretty striking and pretty obvious that our outcomes are the worst.
What's so depressing is our outcomes are the worst, but we spend overwhelmingly the most.
Yeah.
Like, we are currently spending how much for GDP? 16.8%, 17%, something like that?
It was over 17% in 2022.
There we go. Yeah, my data's from 2019. So it's 22%, what'd you say?
It's over 17%.
Over 17%.
Yeah.
The next one, the closest to us is Switzerland at 11.
Yeah. Yeah. It's crazy. We spend between $9,000 and $10,000 per capita on our healthcare. Second most is between $6,000 and $7,000. We spend a crazy amount, and on top of that, we have 8.3% of our population uninsured, compared to 0% uninsured in Japan, 0% uninsured in the United Kingdom, less than 1% uninsured in France, less than 1% uninsured in Germany, less than 5% uninsured in China.
We're getting beat out in healthcare by China.
China is not... Okay, China has the number 2 GDP in the world because they are an enormous population, but they're not a rich country.
No.
Their GDP per capita is like a quarter of ours. This is absurd. This is a huge L that we're taking.
And it should make everyone angry. You should be demanding more.
Yeah.
We are a better country than this.
Yes.
And we're not fighting to make it better. Our elected officials aren't fighting to make it better.
No. This combination of stats should be remarkably embarrassing. Other countries should laugh at us.
Yes. Honestly, other countries should invade us, change our government, and give us free healthcare. That's what they should do.
Yeah.
And it's just, it's one of those things where this should be a national outrage, and Americans are just I don't think Americans think that anything can be any different. Like, this is just the way it is, you know? And they just think like there's no way it's ever going to get better.
Yeah.
But where does America's system suck? One of the ways American system sucks so bad is our administrative efficiency. So because these other countries have universal systems, a lot of them have single payer systems. Some of them are multi-payer systems. Some of them are totally government-run systems. But what all of those have in common between them is they have very standard payment processes. Well, in the United States, the documentation, the paperwork, the bureaucratic tasks for each patient all change based off the type of insurance that person has.
Yes.
So U.S. doctors are the most likely to have trouble getting their patients medication or treatments because of restrictions of insurance coverage. Compared to most other countries, large percentage of U.S. adults in the United States say they spend a lot of time on paperwork related to medical bills. Medical bills don't exist in a lot of parts of the world, guys. We're one of the only countries in the developed world that has medical bills.
Yep.
Get angry.
Well, this is the result when you have the standardization that a single payer plan produces, or even in these multi-payer system where they are not so blinded by the need for free markets and capitalism that they're allowed to impose some regulation on how billing is done, on how the insurance is administered, it totally reduces costs. Like,
so much.
amazingly.
I mean, and we'll get into that, how much that actually reduces costs.
Yeah.
But on top, and so in addition to this is the last point I have on the administration stuff. The United States and Canada are the least likely, specifically the United States. Canada is a very, 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 very distant part from the United States. But the United States are the most likely to visit an emergency department when they don't need to visit the emergency department. They need a primary care doctor.
Yeah. So
America has a massive primary care shortage, which we'll get into, but they're the most likely to go into emergency centers, which are the least efficient way of seeing a regular doctor.
And one thing I would say here is one of the reasons our emergency rooms are often so filled up is because we have such a terrible homelessness problem. Homeless people are the majority of stays that occur in emergency rooms. And so that there are multiple ways in which other systemic issues that we have in our country feed into this massive healthcare burden.
Yep.
And that's one of them. So we're not really going to get into that today because that's a little bit too much.
Yeah,
for
it's
this
too much.
conversation.
Yeah, maybe we'll do homelessness at another time.
Yeah,
because that's a good topic.
But it's so interesting because you mention like the people using emergency rooms too much. Generally, there's been an idea that there's overutilization in our healthcare system. And so I don't want to stray too far from administration here.
No, it's okay.
But there's been a general consensus for a long time that we're wasting a lot of money on healthcare and over-treating people because we have this fee-for-service model.
Right.
And I'll argue later that that's really not the main issue. But because that's the consensus, it gives rise to utilization management activities like prior authorization for treatment, or it encourages insurance designs that charge more out of pocket to discourage people. And what does that do? Causes more administration. It needs more administration work to handle.
Yes.
Right? So that's been building it up.
So I want to talk about how people are saying that we're overutilizing our healthcare in the United States. We are so underutilizing what we should be doing. And the Commonwealth Fund found this. In the United Kingdom, 12% of low-income people have said that they skipped a doctor visit due to costs. In the United Kingdom, 12% low-income people. Sweden, 19% of low-income people. In the United States, half of low-income people said they skipped a doctor visit in the last year due to costs.
Yeah.
And this is a very unique problem. The next closest country is New Zealand at 27%. The United States is double that at 50%.
Yeah. Our health, I mean, it's a perfect microcosm of a general issue where our system is so focused on treatment rather than prevention. Which again makes sense because of the capitalism that is baked in, right? Because all of these health providers can afford to charge more for the treatment rather than the prevention, because people will skip the preventative office visits, right? But they won't decline the treatment for the potentially life-threatening problems.
No, of course not. Of course not. Like, what's the price? What's the price you're going to pay to cure yourself from cancer? Anything.
Exactly.
You'll give your leg, right? You'll do anything for it.
And people are all the time.
Exactly.
Yeah.
They're going into medical debt. Medical bankruptcy is the number one cause of bankruptcy in the United States.
Yeah.
Which isn't a thing in the developed world. Medical bankruptcies do not exist in the developed world. It doesn't happen.
Yeah. It's just sad.
It is sad.
Honestly.
It's the worst. And
the one other thing I wanted to mention on the administration front is electronic health record systems.
Oh, yeah.
So this is important because there are a number. So there are three biggest players, but there are a number of other players in this space that track medical records, and they all work where there's no communication that can happen between them, because they want to lock their clients in to only using those systems. And what that means is when you do want to transfer medical records and you maybe have to transfer them to a different system, Again, so much more paperwork, so much more administration. This is a place where these other countries have regulated that all of these electronic health record systems, EHR systems, can talk to each other easily. So you don't have to worry about all that.
Yep.
And again, I'm just going to keep hammering this home. It is our government's reluctance to play any kind of part in this market that has allowed this to happen, which is burdening the consumer enormously.
Right. This is all a choice we're making.
Yeah.
This is all a choice we're making. Totally. And that's what I definitely want to hammer home is all of these things are choices. I'm going to read off another stat here where it talks about preventable mortality deaths per 100,000 people. In the United Kingdom, Yeah, in the United Kingdom, it's 93 deaths per 100,000 that are preventable. In the United States, it's basically double that at 177. We are unique with this problem. The next closest to us is 119 per 100,000. That's Switzerland.
Yeah.
We are uniquely bad. I want to talk about our progress with this. So when we look at avoidable deaths and 10-year reduction in avoidable mortality across countries, since 2009, Switzerland has seen a 25% reduction in avoidable mortality. In Norway, you've seen a 24% reduction in avoidable mortality. In the UK, we've seen a 19% reduction in avoidable mortality. In the US, we've seen a 5% reduction. We're not making progress the same way the rest of the world is, and that's why our life expectancy is going down.
Yeah. I'm curious where you would break this down. To me, it's one, people are discouraged from going to the doctor because it can bankrupt them. But this is another place where I feel like the other societal issues come in. Our fentanyl problem, right, is a huge contributor to this. Diseases of despair is something we learned about in Stiglitz, right? And how they're higher in the US than anywhere else in the developed world.
Equivalent to 1990s Russia.
Yeah. Yeah. And I think that's a huge contributing factor here.
Oh, totally.
Yeah.
That is definitely where a lot of the excess mortality is coming from. It's coming from suicide.
Yeah.
It's coming from drug overdose.
But it's also, it's a positive feedback loop in a very negative area where not providing these people health care is what's leading them into the despair, right? Feeling like they can't go get help without being bankrupted. What more despairing situation can you find yourself in?
Where are you going to turn to when the whole country is like, yeah, if you try to get help, we're going to take your house from you?
Yeah, it's absolutely ridiculous.
There's no incentive for people to get better, and it leads to death.
Yeah.
It's just so sad.
So I was going to talk about what are the underlying causes of these costs being so high? Because I think that's where I kind of landed as one of the root issues here.
Okay.
And I mentioned before, there's this conventional thinking that a fee-for-service model has encouraged healthcare providers to overtreat, right? Because the more services they give, the more they're paid by the insurance companies. But there was some data released comparing OECD countries in 2018 that challenged this and kind of rejected it, in my opinion. Because it showed that American utilization is actually pretty similar to every other country, except for imaging, which actually is which is one part of this that supports that wasteful treatment hypothesis. We do many more imaging,
a lot more
CT
MRI
scans,
stuff.
MRIs on people, and we charge a ton for them. But there's other kind of disconnected but important cost drivers. So first of all, hospital costs account for 31% of health spending that we do in this country, by far the biggest factor. They charge a ton for their procedures and tests like MRIs. And the reason that these costs balloon up so much is because of consolidation that's been happening in our hospitals. Another thing, apparently Stiglitz is really kind of my guy for this kind of thing that's happening. But we read about how many industries were kind of getting closer to oligopoly and monopoly. Well, this is even worse in the hospital space because hospitals aren't national industries.
Right.
They're local industries. You don't want to go 10 miles to go to a hospital.
You want to go to the closest.
Exactly. Much less 20 or 30 or 40 and 50. And so the thing is, in these rural areas, which the United States has a lot of as a very large country, there are very few hospitals and people do have to travel farther. And so companies, massive kind of hospital conglomerates, have seen those as opportunities to become monopolies. Mm-hmm. So Appalachia is a great example where I'm forgetting the name of it, but one of these companies bought up every hospital kind of within a 100-mile radius of one spot. And as soon as they were able to do that, just as a monopoly works, it was able to jack up their prices. And so how does this payment exactly work? Insurers negotiate on prices of services with the healthcare providers, right? So if insurers want to cover a certain area that's been monopolized, they can only negotiate with one hospital group, right? And so once that's the case, it's like, okay, you can either not cover this entire area, or you can pay whatever prices we ask of you. And of course, the prices that the insurers pay get passed down to people in copays and in the premiums they pay. Studies found that 75% of hospital markets are now considered highly consolidated.
Wow.
Biden's administration, their FTC, has blocked 7 mergers in the last 2 years. They've been on this. They've been trying to stop it, but there were still 53 acquisitions in 2022.
Oh my God.
It's a very hard problem to stop. And it creates a positive feedback loop because comparatively, independent doctors have very little bargaining power with insurance companies, right? And so they are incentivized to join these hospital groups, which also give them more regular hours, less administrative hassle.
Right, it's an economies of scale beneficial. You're benefiting from the economies of scale by joining this.
Exactly. Price opacity has also been talked about as a contributor to the problem.
Right, where you can't see the prices of the things that you're trying to do.
Yeah, a lot of times people go and they're like, I have to get treated. It's a medical test. But honestly, that's also been kind of debunked.
Yeah, like, what are you going to do? They're like, I'm going to drive 30 miles longer to save $200.
Yeah, people just do what their doctors tell them.
Yeah,
is the thing. And the crazy thing is, and I was listening to a podcast on this, because of this consolidation, this monopolization, there are some hardcore economists that want price regulations on what these hospitals can charge. And price regulation is like the dirtiest word an economist could ever hear.
Yeah. I mean, I love it.
I love it too. Yeah. So yeah, that to me is kind of probably the most core reason. And then everything else comes down to, not everything else, but administration is another big part. And there are other things that a universal healthcare system would help massively with.
Well, one thing I focused in on was the lack of doctors in the United States.
Me too.
And that's a huge burden because it makes doctors, I'm glad doctors make a lot of money, but they make so much money as compared to everyone else in our society because the United States is very unique in how little we have of doctors, specifically primary care physicians. Yeah. So in comparing these countries through the Commonwealth Group, we have the United States as last, as the number, out of those 11 countries, we are the worst. Mm-hmm. Norway is the best among the 11 countries. They have a lot more supply of physicians per their population. Mm-hmm. And here are the numbers. The United States is down at 2,000. What is it? Oh, no. The United States is down at 2.5 doctors per 10,000 people. Denmark is up at 23 doctors per 10,000 people. Norway is at 27 doctors per 10,000 people. All right, that's a little ridiculous. The Nordic countries are always great for everything. Let's go to the United Kingdom where their country kind of sucks. United Kingdom, 7 physicians per each.
Yeah.
So we are absolutely failing. And the United States is actually unique in having like a larger proportion of specialty doctors versus primary care doctors. And the reason for this is people who want to become doctors have to do 4 years of undergraduate school. Then they have to do 4 years of med school. Then they have to do 4 years of residency, or however long med school is. I don't know. 2 years? I don't know.
3 to 7.
3 to 7. Yeah. Okay. So there's so much, and then the average person in the United States comes out with $200,000 to $300,000 in medical in student loans.
Yep.
So they have to make a lot of money.
Yeah.
So they get pushed into specialty groups and specialty programs where they can make $350,000, $400,000 a year instead of primary care / pediatric care where you make $200,000.
Yeah, I have some numbers here on specifically how different salaries are.
Oh, good.
So for generalists in the U.S., it's $218,000. That's nearly double the mean of these other OECD countries.
Yep. Norway's at 110.
Second place is Germany at 154,000.
Oh my
So
God.
we're 42% higher than second place. Specialists, $316,000 is our average. Versus 202,000 in Australia. We're over 50% more. And we even have to pay our nurses more than everywhere else. We pay nurses 14% more than second place Australia. I went pretty deep on this too.
Good.
And I have a lot to say. Lowering doctor salaries could be part of the solution. But what I found is that doctors' remunerations are estimated to account for less than 10% of total health spending.
What is remunerate? What is that word?
Salaries.
Okay.
Yeah. What doctors are paid.
Yeah, I knew what it meant. I just didn't know if the
you were
audience
testing
would.
me. Yeah. So yes, it could be a problem. I did go deep into this doctor shortage because
I'm talking about, I'm not saying that the doctor salaries are a problem, but why are the salaries so high? And then that's the problem.
Okay. Because the shortage?
Because the doctor shortage.
Okay. You think the shortage is the problem?
I think the shortage is the problem.
So did you go into why there's a shortage?
Yes.
Yeah.
About the number of MDs that have been given out.
Well,
You go first. I'll give mine after.
because mine is residencies.
Okay.
Is the bottleneck here?
Okay.
Oh
yes.
yeah. So what I found is that there are about 0.8 residencies available for every medical student that graduates med school. And so that might not seem like that big of a difference considering like the acceptance rates that people hear about going to college, going to grad school, going to med school. But it's already such a tiny, thin funnel to get people into med school. To not be able to train all of those people to be doctors is an enormous problem.
Mm-hmm.
And that is what's stopping. Like the residency spots need to expand not just to 100% of med students that are graduating, but to more than that.
Yep.
So that the med schools can accept more students.
Absolutely. And then that bottleneck, it's devastating. Could you imagine doing all that money to go to med school and then not getting into a residency program?
It's absolutely absurd. To pay that amount of money and not get into residency is crippling.
Unbelievable.
Yeah.
So now there's another aspect to this. The amount of doctors who join the workforce every year. How many MDs are given out every year? Well, in 1980, this is
I don't want to bulldoze you, but I want to talk. I have more about the residencies.
Oh, then go
it would
about
probably
the
just
residencies.
make more sense.
Okay,
So there are not enough residencies. I just want to go into why is this the case,
Mm-hmm.
right? People know that this is a problem. So residency spots are funded by the Medicare program, and there's a portion of it that it spends about $15 billion a year on residency spots in the country. Here's the thing, though. That was set in a 1997 piece of legislation called the Balanced Budget Act.
No.
That cap was always expected to be raised. It never was.
Oh my God.
We've been funding the same amount of spots with the sole exception of a modest increase of funding from one of the 2020 COVID bills.
Wow.
Okay, it created spots for 1,000 new residencies. It's not nearly enough. Right now, 70% of hospitals train more residents than Medicare funds for. So it's getting funding from other places, but the Medicare funding is still the vast majority of what they have. But the problem is more complex than this. It's not only the lack of funding, there's a lack of teachers. So they're called preceptors in this case, the doctors who are actually going to teach the residents. This is so messed up in so many ways. So there's a lack of supply of training sites, which is partially due to that consolidation I was just talking about earlier, right? Doctors are being given more work because they're in hospitals that are maximizing their hours, and oftentimes they're given billing targets once they are working for an organization,
Wow.
which means that they have to spend all of their time treating patients and they can't even sign up to try to be a teacher. Furthermore, there are many more non-medical students that seek these spots and get these spots. They apply to them, including nursing students and physician assistant students, PA students. So we have these problems of we need more funding and we need more preceptors. Meanwhile, doctors face the highest rates of burnout ever. There was a survey in 2021 that about 21% of the doctors who were asked questions in the surveys expected that they were going to leave the field in the next 2 years.
That's exactly
Guess
what I
what?
found.
It's been 2 years.
Yep.
So it's like a really bad problem. What are the solutions? Schools are mulling over paying preceptors, but which again, that cost is almost certainly going to fall on medical students, right? In tuitions.
And those tuitions that are going to be paid for with student loans that are not defaultable, not bankruptable.
Yeah, exactly. They're looking further away to send students off to training centers 40, 50 miles away. Which just makes life more hellish for medical students that are already working.
De-incentivizing the wanting to be a doctor.
Yep, hours. The one that I really like that's already been started in a few states is offering tax credits to preceptors, up to like $1,000 of tax credits per student
that's great.
that you teach. This has already begun in Maryland, Hawaii, Ohio, Georgia. So that is a direction that I hope more states go. Sorry that I
No. I
just
love
took
that.
all that time, but yeah.
No, that's so important. I did not know that the preceptors were such an issue at all. I had no idea.
I had to get
and
deep.
I am shocked that $15 billion number for residency funding has not really been raised since 1997.
No,
that's
truly.
unreal. That's unreal.
That's crazy.
I mean, it's just, and then that makes perfect sense as to why this is happening. So I took a little bit of a deep dive into where how many doctors are joining the workforce every year. So in 1980 is our base year, okay? After 1980, there was a feeling in the medical community.
There was a report.
There was too many doctors.
Yeah.
And in response to this, we capped the number of MDs that were being given out over the course of like 1980 to 2005. We capped it. Okay. And because of this, we saw the population of the United States keep going up. But the number of doctors that graduated every year at 1980 just flatlined. And we hovered around 80% growth for doctors, but, still continual 100% growth to the population. So we're seeing a 20% gap open up every year. When the moratorium ended in 2005, we started seeing that increase again. And eventually it will catch up. It looks like it's catching up. But there was a huge gap created over these last 25 years caused by bad government policy.
Yeah.
And also, 1980? Who was president then?
Yeah.
Ronald Reagan. I'm sorry, Mr. Free Market Guy. Why are you limiting the number of doctors that we're able to make? I don't understand what's happening.
Okay, so this is a point where I want to bring in a little bit of older history, because we have a long history of thinking that we need to limit the number of doctors in this country.
Really?
In 1910,
no shit,
a document came out. A guy named Abraham Flexner
what a bitch,
came out with a report which specifically advocated for having fewer medical schools and thus fewer doctors. So this came from a few places. He thought that quality wasn't consistent enough across the spectrum. And most people who are post-college will know that Johns Hopkins is like the best medical school and undergrad medical programs in the world. It came from this. Flexner used Johns Hopkins as his gold standard in the report. And so this was enormously influential, not only in tightening standards for medical schools, but in encouraging them to admit fewer applicants. And it set the standard for our entire medical school residency system.
Wow.
So listen, it is only the US and Canada that has this whole 4 years undergrad, 4 years medical school, 3 to 7 years residency. What happens in other countries is they
6
do
years.
5 to 6 years undergrad, and that undergrad study is their medical school study, and then they become doctors. And Flexner was like, we need to be more stringent. And this program is doing so much damage as far as discouraging people from entering the workforce and just removing potential doctors, even who do reach the end of certain points, who finish undergrad, who decide not to go to medical school, who finish medical school but don't have residency spots available for them.
Yep.
And it's wild that our system, since our system grew around that report now, we're so ingrained in it.
We're stuck in it.
That like trying to transition out of the med school residency system seems impossible.
It seems like a daunting task. I can't even fathom how you would do that.
No.
It's almost like it's so difficult to imagine the world that you're a world different from what you're currently living in, right?
Yeah.
It's easier, this is a famous quote, it's easier to imagine the end of the world than it is to imagine the end of capitalism, right?
Yeah.
And that's how I feel about that.
I agree.
It's easier to imagine a world with no doctors than ones that don't go to undergrad and then medical school.
Yeah.
But that's how the rest of the world operates. And I think one of the things the United States should do as a prescriptive thing, I think the United States should allow doctors from Canada to come to the United States and practice. I think the United States should allow doctors from other European countries, Norway, Denmark, UK, France, to come to the United States and practice here. And we should try importing their doctors, because as much as we need reform here, we have a bubble of open spots built from that 1980 moratorium on MDs that we need to fill right now, because we're going into this retirement age of the baby boomers, and we need to pump people in to fill that hole right now.
I definitely agree with you on principle, but because we have such a messed up administration system, I honestly don't know if we could attract them. These doctors have to do so much work that they weren't trained for and that they don't like.
No, that makes a lot of sense. And that makes a lot of sense. I mean, the United States is the only country among comparative countries that employs health navigators. Yeah. And these health navigators help people get around their insurance. So you don't only have to pay for your insurance, you have to pay for somebody to help you use your insurance. United States is the only one that has that.
It's ridiculous. I have one more thing I want to talk about on the price issue, which is pharmaceuticals, which is like the biggest political issue that I think comes out of this. Obviously, like everything else, we have the highest pharmaceutical spending per capita by far. We do.
Why wouldn't we?
54% more than second place Switzerland. For 3 common pharmaceuticals, the U.S. price is more than double the next highest country. This is something that the Biden administration has made progress on, because they made an update to Medicare Part D, which is the provision of Medicare which provides for pharmaceuticals, that the government is allowed to negotiate on pharmaceutical prices.
Thank God.
Which it hadn't been able to do before. And so this is going to be big, not just for people with Medicare, but for bringing down prices across the board.
Yeah, this is going to be huge. They were looking to get it also applied to the private sector. That ended up not going through. They tried to get an insulin price cap of $35 in private and public healthcare. They only got it in public, not all the way in private. Some private suppliers of insulin has come down to $35 in response to the negative public backlash from the administration, which is really great to see. But they didn't get that done from a policy perspective yet. But yeah.
But I mean, to me, that perfectly translates into what I think the last part of this conversation should be.
I want to do one more thing.
Okay.
I want to do one more thing on comparing us to the rest of the world.
Yeah.
I read a lot about Norwegian healthcare.
Yes.
Because Norway has the best one in the world. They have the most amount of doctors per person. They have a very, very great way of funneling and creating doctors. And I want to just talk about how Norway works, so maybe we can learn something.
Yeah.
So in Norway, there is universal coverage, and it's funded through general taxes, payroll contributions, okay? Patients make co-payments for some services and products with caps on out-of-pocket expenses. The way that it's organized is, I think, a great blueprint for how America could organize a similar system. Municipalities organize primary healthcare, while national governments is responsible for taking care of hospital services, sometimes through mostly through state-owned regional health authorities. I don't think state-owned authorities will work in the United States. I don't think we have the political appetite for that. I wish we did, but we don't. But municipalities organizing primary healthcare, I think that is key to what the United States could take from this. 10% of the population in Norway does have private insurance. And the reason they do is to have quicker access and greater choice to some private providers. So there is a multi-payer thing going on here.
Public option.
The public option, exactly. They began the system. This is what's really so crazy to me. The system actually began in 1909. Their national healthcare system began in 1909. And this was for poor workers and their families. But other citizens were allowed to opt out. In 1956, converted it into a fully universal and mandatory right for all citizens, not just for the poor, but for everybody. And now, what does it cover? It covers primary and ambulatory care, hospital care, mental health care, rehabilitation, outpatient prescription drugs, if the drug is in the national formula, preventative services, maternity care and maternity care from a midwife at a clinic, home-based care, and a word I don't know what that means, medical equipment on a needs basis, and dental care. Medicare in the United States for people ages 65 and up currently doesn't cover dental care. Norway covers dental care for everybody, and they have a GDP per capita that's less than ours.
And I'd be very confident in saying that the caps on copays in Norway are much lower than what people pay for copays for Medicare.
You would be right. Where do the doctors come from? Medical education programs are offered through 4 public universities. The yearly educational capacity is 600 students, and the tuition fee is about $118. $118 a year to go to medical school in Norway. In the United States, what is it? 90 grand?
Yeah.
Why are we doing this? Why have we made this decision? Registered residents have the right to go to a general practitioner of their choosing, assuming the physician has capacity, The average patient per practitioner, or the average panel size, is 1,120 in Norway. In the United States, it's 2,500, more than double. Okay? So, and this is what I like so much about the municipality system. The municipalities contract individual primary care doctors. And those primary care doctors are mostly self-employed. Only 6% are salaried municipal employees. They're not state-owned.
Mm-hmm.
They're reimbursed by the state.
Yeah.
But they're not state employees.
Okay, so this is where the cost savings from a universal system come in.
Massive.
Okay, because it's a word we've used occasionally on this podcast before, monopsony power. To have a single buyer means we have kind of, rather than these massive hospital systems having all the bargaining power, our government has all the bargaining power because they're the only insurer. So they get to be like, no, we don't want to pay $2,000 for every CT scan you do. We know that only costs you $150. So we'll pay you $200. We'll throw you a bone.
Yeah, exactly. And Norway is able to really benefit because of that monopsony power.
Mm-hmm.
And the last thing I'll say about Norway, long-term care costs, long-term care facilities. 90% of nursing homes are funded by municipalities. Only 10% are private nursing homes, but even those are nonprofit.
Yeah. When I hear all this, I just think of how much safer, how much more supported would you feel in a country where the baseline is there's always someone ready and waiting to take care of me, versus if I try to get someone to take care of me, I could lose everything I have.
Everything. Again, health medical bills are the number one cause of bankruptcy in the United States.
It's just night and day, and it is sad. Like, it's sad to think about that burden for people to have.
No, I mean, I when my mom was growing up, she broke her nose, and they weren't able to go to the hospital because they didn't have health insurance. So my mom lived with the broken nose and just waited for it to heal on her own. They got a splint from, one of their friends, and they made like a homemade one. It's like, that's not the world we should be living in.
No.
That was in the 60s, right? But Norway had universal health care by 1956. And I get it, guys. Norway's a smaller country, whatever with that.
Well, here, so
You can apply it to scale.
let's get into why.
Yeah.
Why not?
Yeah, why
Right?
not?
So it was floated in like the 40s, 50s, and it was actually, I found an article that talked about how it was initially proposed by the National Medical Association, which arose out of the Freedmen's Bureau, because
And we've talked about that in the past.
yes, which was formed out of from the slaves being emancipated after the American Civil War. In the South, after the Civil War, there were diseases that rampantly ran through black populations, including smallpox. And so it was kind of unsurprisingly mistreated or not paid enough attention to by the majority white establishments.
Shock.
But the National Medical Association was formed by black doctors, and they proposed later on universal health care. But because racism was so powerful at the time, that was one of the major reasons it was shot down. It was also just post World War II, and it was called out as socialist, a critique we still see constantly today to call out any big government program. And so that's kind of why we still don't have it. But the other reason, I would say, it is the cost.
Yeah, the cost.
Estimates for the cost range from $24 trillion to $36 trillion over 10 years, which is a lot. Universal health care has actually been tried before in the United States, in Vermont.
Yes, it has.
It was tried in 2011, and they actually never figured out a way to fund it. The proposed tax plans that they would have had to implement to fund it was decided that they were too high and would potentially cause economic shocks. And so it never actually happened. Now in Vermont, they still are campaigning to have universal health care to bring it back. A lot of the citizens are disappointed. But I guess the more pragmatic politicians decided that it wouldn't be possible.
Well, I'll tell you this. To make this happen in America, it has to be national. Can't be done on a statewide basis. Can't happen. We need the power of the federal government fully behind this if we're going to make it work. And we need to, because we need payroll taxes to make this work. We need larger progressive taxes on the wealthy to make this work.
We're going to need enormous progressive taxes. I want to make that very clear.
Yeah.
We would need this 24.7 trillion, or 36 trillion, if you say 30 trillion is kind of the midpoint of these estimates, that's 3 trillion a year. That's about 60% more than all of the taxes we brought in last year.
Yep.
So we need a lot more taxes.
Where do we get that money from? I think it's a simple answer. The average typical family of 4 with an employer-sponsored health insurance plan spend about $28,000 a year between the employer premium and then their contribution. The employer spent 56% of that. The employee spent 27% of that. And then the out-of-pocket expenses was around 17%. $28,000 in total. That's all going to the private insurance company. The United States government needs to take that $28,000, take about $24,000 of it, leave you with a profit of $4,000, and take that $24,000 and fund a national healthcare system. That means middle class taxes going up.
Yeah.
That means working class taxes going up. But it's all going to be worth it when you do your taxes at the end of the year and you realize, oh my God, I have more money in my pocket because I have no copays, I have no deductibles, I have no more health insurance premiums. At the end of the day, you will be in the green, guaranteed. And not only will you be in the green, the nation as a whole will most likely be in the green.
Yeah.
The Congressional Budget Office did a report in 2020, and they said the various specifications for national health expenditures ranged from a $0.7 trillion decrease to a $0.3 trillion increase by 2030 if Medicare for All was passed. That's suggesting that we could have it's more likely we decrease our national health expenditures by passing Medicare for all than not.
Yeah.
We would be saving money, most likely.
Yeah, I found a study that said $450 billion a year.
Beautiful.
Probably. I think it's almost certain that we save money. Again, these administrative costs are going to plummet if we have a uniform system. And I think you explained it perfectly there. It is the challenge of progressives to continue articulating it that eloquently over and over again.
That is the battle that we are going to have, and we need to win.
Yes.
There are too many people who are suffering and who have been suffering for too long for progressives not to win this fight, or for gutless politicians to not be able to go to the stage and say, yes, middle class people, your taxes will go up, but you're going to be happy they are because we're going to give you the best healthcare in the world, because Americans can and should have the best healthcare in the world.